Good afternoon. I would like to welcome everybody to today's webinar, where we are looking at the topic, choosing the right antihypertensives combination. So we have Augusta Pharmaceuticals bringing this program in collaboration with Zambia Medical Association. I will be your host for today's program. My name is Dr. Nguira Innocent. I'm the Ethics and Professional Conduct Board Chairperson for Zambia Medical Association. I'm standing in for Dr. Chuma Njovu, who is unable to be with us due to some other commitments. So I would like to state that as we come into the program, let's just go to the chat box and put our full names there, as well as our facilities for the sake of the register for the CPD points. Without wasting much of your time, allow me to introduce the speaker, who is Dr. Manish Chandi. So Dr. Manish is quite an experienced clinician. I think those of you who have had time to go through his profile would appreciate that definitely we have the right person to discuss with on this topic. Yes, as we are all aware, hypertension is it's a big problem. And also, I think with the exception of physicians, for most of us, it's something that is, we all understand that hypertension is a silent killer. And obviously, we have come across a lot of patients, regardless of having different conditions. Some of the patients who have comorbidities and hypertension as one of the top problems. So I think it is necessary that we go through this topic and also ask the right questions and get the correct advice on how to proceed. So our program is quite brief and straightforward. So I'll start first with the presenter who take us through the whole program. And then after that, I'll allow one of the company representatives from Augusta Pharmaceuticals just to tell us about the company and also their products. And then after that, we can allow questions on the topic as well as on their products. I think that will sum it up at the end of it all. So, Dr. Manish, I'm sure you are ready.
Good evening. Thank you for inviting. Can I have the screen?
Yes. So I think at this point I'll allow Dr. Manish to speak to us and go ahead with the program. Over to you, Dr. Manish.
Thank you. Thank you, everyone, and very good evening. And it's a pleasure, honor to be present and to be part of this academic activity. And I would try to justify my presence to the max and see how best we can together make a change in the practice that we are doing and reinforce the practices, the evidence that are there in management of hypertension. So as the topic today is combination therapy, as we talk about combination therapy, to start brief about hypertension. Hypertension, as per the WHO 2023 September update, it is 1 in 3 adults in the world is suffering with hypertension. So among us, if we are 100 people sitting here, around 33% of the people in the hall are suffering with hypertension. In this group is suffering with hypertension. It is just that somebody is aware, somebody is not aware. Around 10 million deaths and more 10 million deaths and over 20 million disabilities happen because of hypertension per year It is a leading cause of ischemic heart disease, hemorrhagic strokes, ischemic stroke. Hypertension is one of the leading cause of these problems today. And we talk about epidemiology. It is said that, in Africa itself, the hypertension prevalence ranges between 37 to 57%. So it is quite alarming, 37 to 75%. And if you take the southern part of the Africa, the prevalence is around 47%. If you take hypertension as 140 by 90, which is the cutoff mark, which is approved by international guidelines, and 130 by 90, which is the American Association of Hypertension, American Society of Hypertension, and American College of Cardiology's ACC ASH guidelines, where the cutoff is 130 by 80. If you go by the latest cutoffs, 130 by 80, the prevalence of hypertension in South Africa, southern part of the Africa, will increase to around 67 whopping percent. 67% of the population would be hypertensive. And if it stick to the 140 by 90, the hypertension prevalence is around 50% in southern Africa. And this is quite a huge alarming number. Now, why is it important for us to reduce the blood pressure? Is it just the number game? Is it just the numbers that we are trying to figure it out? Or is there any benefit of reducing the hypertension? So it was clearly seen in the study that as we go from here, as you reduce your blood pressure by 20 mm, you can see that there's a major reduction. This is the reduction in the cardiovascular events. You have reduction in the cardiovascular events. So this is what it says, that once you reduce your blood pressure by 20 mm, once the blood pressure is reduced by 20 mm, there is a major reduction in your cardiovascular risk. And not only in your myocardial infarctions, but also in peripheral arterial disease, also in erectile dysfunctions, and also in your hemorrhagic and ischemic strokes. All these vascular diseases, what happens is that when you have hypertension, when you see these patients with hypertension, you know that by reducing the blood pressure, we will be able to reduce these various complications of hypertension. As you see in the below diagram chart, you all major cardiovascular events, coronary artery disease, stroke, heart failure, renal failures, all these are in favor of reduction of your systolic blood pressure. You reduce the systolic blood pressure, we preserve the kidneys. You reduce the systolic blood pressure, you preserve your heart. You reduce the systolic blood pressure, you protect your brains, you protect your other vital organs in your body. And that is why it is important for us to reduce the blood pressure in our patients, to explain our patients why is it important for them to reduce their blood pressures and bring it to the normal levels or the optimal levels as much as possible. Now, the African Society, Pan-African Society of Cardiology, they had a 10-point agenda. They have introduced a 10-point action plan, which is going to help achieve 25% hypertension control. So what the target is to achieve 25% hypertension control by 2025. Now, let me ask the audience here, what is in your estimate, is the present hypertension control rate in that you believe that would be there in Africa right now? Anyone? What is the control rate of hypertension in African population? This is where they have come with a 10-point agenda. The 10-point agenda is to achieve 25% control. One of the major factor in the 10-point agenda is there are various factors which are resource-driven, fund-driven, which is beyond the control of a medical practitioner. But one thing that a medical practitioner can always do is practice evidence-based medicine, evidence-based practices, so that we can provide the best medicine, best treatment to our patients, so that it is going to help them achieve their target goals and maintain a good, healthy blood pressure in these patients. Now, this is a study which was presented in 2017, and it speaks about the challenges and unmet needs of hypertension in an African setting. We all know that, India, Africa, Asia, these are all resource crunched environments. We have severe poverty, lack in infrastructure, medical facilities, availability of medicines. All these challenges exist in our part of the world. And you see the total hypertension is around 100%. Out of 100%, only 50% are screened. 49% of the patients do not know that they have hypertension. Only 50% of the patients are actually screened and they know that they have hypertension. Out of this, only 28% patients are actually diagnosed with hypertension. So the the prevalence is 1/4 of the patient are actually diagnosed with hypertension, and only 22% of the patient really take treatment for hypertension. And out of this 22%, the only 9% of the patients are actually managed with a proper, have a controlled blood pressure, have a controlled blood pressure. So what do you mean by controlled blood pressure? Controlled blood pressure is, suppose I set up for my patient that his systolic blood pressure should be less than 140. Or I set up based on his cardiac parameters or other end organ diseases, I set his or her renal blood pressure target as 130, or maybe an elderly population coming, I set the blood pressure as 150. So that is the target level. And among these patients, only 9% of the patients are actually achieving this target goal, which has been set by the physician. So physician needs to set an aggressive goal. We need to set a goal for our patient. We need to get little aggressive in our approach to the patient so that we can at least achieve. So these are achievable. We have a 22% patient who are coming for treatment, and at least we should strive that we achieve maximum number of patients who are following our treatment. They achieve a BP goal, their BP targets. So this is where it is. Now, looking into the burden, it was proposed that let us control in case, let us by 2030, 2030, let us at least control 50% of the patients who are there. Let us give them a good controlled result. So 50% of the patients who are there, who are coming for treatment, who are getting treated, let us try and achieve a control. So the target is that awareness should be there among 80% of the population. Around 60% of your population should at least go for a treatment, and at least in that 60%, 50% of the patients should achieve their BP target. So if I set a BP target, if you set a BP target, your patient, 50% of your patients should at least achieve that BP target by 2030. So this all changes will happen by various infrastructure changes, various resource management, various fundings from the government and other organizations, and obviously with the collaboration of the physicians and practice of following of the newer guidelines, management strategies that are being implemented across the globe, and which can be implemented best suiting for the patient that we are treating. Now, what is the reason for uncontrolled or poor control in our patient? What are the reasons? Why is it not getting controlled? Why are that we are going to, what are we going to do about it? So what strategy are we know that we are not able to control the blood pressure, or we are not achieving that target level. So what are we doing about it? Then can we stick to the old guidelines? Can we follow the old procedures, or is there something new that we can add on to our practice which will help us achieve that kind of targets that has been set? And is there something different that we need to do from the present practice? So these are some of the thought questions that maybe you should ask, or maybe we should ask as the clinicians to ourselves in helping our patient achieve their target blood pressure. So why are we not able to treat? Is it that the drugs are not working? Is it that the patient does not like to take pills, or they don't want to take multiple pills? Physicians often do not escalate the treatment. So, the patient comes with a blood pressure of 170, and he says, I have headache, I have giddiness. I've given him a medicine. The blood pressure has come down to 160, 150. My target was around 140. Now, what do I do? A patient feels that he's completely fine. He's okay. He feels that he is perfectly fine right now. So do I need to aggressively go further and add on another drug to change, to see that he achieves the target of 140? Or should I just leave him as it is and say that, okay, you are happy and I am happy, and let's continue with it? So this is where the physician needs to decide whether he needs to escalate the therapy, and is the guidelines are necessary. Are they complicated guidelines, or is it simple to adopt? Is it helping us in achieving our target level? So guidelines are never a binding factor. Guidelines are never a binding factor. you are not compelled to follow the guidelines, but are these guidelines helping you? If yes, then it is good to follow these guidelines. So let's see what are the guidelines talking about. Let's see what the guidelines are talking about. So when you talk about monotherapy, are the monotherapies really helping us? So monotherapy blood pressure has multiple, pathways, multiple pathology mechanisms by our blood pressures are increasing. We know that essential hypertension, the real cause of hypertension is still unknown. There are multiple pathways, multiple hormonal, neurological, all these pathways come into picture while the patient becomes hypertensive. The blood pressure target are not being achieved. Too many people receive monotherapy. Maybe the monotherapies are not effective. Maybe we are not targeting the right monotherapy in our patient, and that could be leading to uncontrolled hypertension. And if the blood pressure targets are reduced, in case you reduce the blood pressure target, control rate will even worsen. So suppose if I go from 140 to 130, which is in the American Society of Hypertension recommendation, so my target becomes more steep. I am unable to achieve 140, and now my target is 130. So should I shift from 140 to 130? So the international guideline says, no, let's keep 140 by 80, 140 by 90 as the target for rest of the world. Maybe America can follow 130 by 80, Europe can follow 130 by 80. Let us keep 140 by 90. And even the South African Hypertensive Society says that let us keep 140 by 90 for all. And in case somebody wants to go aggressive, if in case you want to go aggressive with your patient to 130 by 80, you are free to go and achieve that target of 130 by 80, and you can do that, but at least try and strive achieving 140 by 80 in your patients. Now, these are various landmark studies which have been done in the field of hypertension, our heart study, your heart study, all these studies which have been done. The average hypertensive drugs which have been used are always more than 2 to achieve your targets. To average number of drugs which were used in these studies to achieve the target BP was always more than 2. So it clearly says that monotherapy is not effective in all the patients. Maybe some patient would be effective with monotherapy. They would achieve the targets with monotherapy. But in majority of your cases of your patients, you would require more than one drug, more than a drug. So you would require a combination of drugs. So that is where the guidelines are shifting towards combination therapy, looking into these evidences. This is a study which was done to see the antihypertensive drugs on daily practice. You can see that monotherapy, only 29% of the patients were on monotherapy. Switching of monotherapy to combination therapy, 51% of the patients who were there on monotherapy had to be switched into combination therapy. So if I am giving 81% patients were on monotherapy, out of 81, 51% patients are now shifted to combination therapy. And in combination therapy, only 14% of the patients were then shifted from combination to monotherapy. So very minor amount of patients, very minuscule amount of patients would require a monotherapy. Your majority of your patient, if you see this number of BP lowering drug classes used during follow-up, one drug, only 22% of your patient. 2 drugs, 30% of the patient. 3 drugs, 25%. More than 4 drugs and more than 4 drugs, 21% of the patient. So 70% of your patient require combination therapy. So why start with monotherapy? Why not start directly with combination therapy? Combination therapy definitely gives you protection against cardiovascular disease. It gives you protection in coronary artery disease. It gives you protection against cerebrovascular disease. And cardiovascular is not only limited to your heart. Your all peripheral vascular diseases would also come under cardiovascular disease, and that where it says that combination therapy would be favorable to initiate. It is always favorable to initiate with combination therapy. You can always de-escalate in case your patient feels that his BP is gone. In case you see that your patient's blood pressure is dropping below 120 or is touching 120, you want it to be near 180, or maybe if your patient's blood pressure is coming to 130, you want it to be near 140. You can de-escalate. You can reduce the drugs. You can bring it to monotherapy, and you can do it. But you will be able to achieve the targets much faster in your patients, much better in your patient. And as we said, 70% of your patient would be on combination therapy, either 2-drug or 3-drug therapy. So you would not miss on the 70% of your patients. And in case you want to escalate, add a 3rd drug or 4th drug, then we can even escalate these therapies. So this is again a same chart which shows that how combination therapy is effective in reducing the myocardial infarction, stroke, hospitalization due to heart failure. Again, in diabetic and CKD patients, you can see that acute myocardial infarction, these are all in favor of combination therapy. So initiating a patient with combination therapy gives an added advantage in protecting the end organ in our patients. Now, the basic function, I have never seen in our life that we have written that the patient died because of hypertension. We always write, when a patient dies, we always write on a death summary, the patient died because of renal failure, the patient died because of myocardial infarction, heart failure, or stroke. So these are the conditions. What we are trying to protect because of controlling hypertension. What is our goal of controlling hypertension? Why do we want to control the blood pressures? It is not the numbers, but these end organs, your eyes, your heart, your brains, your kidneys, these are the end organs that we are actually trying to protect in our patients. And combination therapy clearly is initiating with combination therapy is clearly giving a better protection in our patients. This was again a study which was conducted, a 12-month study which was conducted, which said that initiating therapy with a single pill combination was associated with 53% reduction a patient achieving their blood pressure within 1 year. So 53% of your patient, if you initiate with a combination therapy, 2-drug combination therapy, your 53% of your patient will achieve the target blood pressure within 1 year of follow-up. Whereas when you start with combination therapy or you start with monotherapy, combination in the sense, you give 2 pills, not a single fixed dose combination, you will see that only 34% of your patient has actually achieved that within a year span. So that is where it says that initiating therapy with free drug combination was associated with only 34%, whereas you have, when you give single pill combination, it is 53%. Now, let us see another data from UK and Czechoslovakia. A wonderful data to see. If you give 1 pill, 1 single drug, 1 tablet to a patient, the adherence is nearly around 5%, 2%. What is the adherence coming in a single pill? The adherence over here is around 1% in the UK population. Czechoslovakia, which is little resource limited country, again the adherence is around maybe around 15%. But if you give 2 drug, the adherence is dropping. The non-adherence is increasing. As you are increasing the number of bills, the non-adherence are increasing. And I'm sure this is the practice across the globe, across any practice, any city, any country, that any continent, it would be a similar practice that is there. Nobody, my mother does not like to take multiple pills. I would never like to take a multiple pill. I would be satisfied if I had a single pill. Even you would be satisfied if you had a single pill to take. So that is why the guidelines, based on all these studies, what it says is that the patient preferred to take 1 pill. And based on these studies, here again, you see that various studies say that it is in the fixed dose combination, which is favor of fixed dose combination, whereas not in favor of your free combinations, giving 2 pills or 3 pills to the patient. Based on the studies, the evidence was created. Based on these evidences, the guidelines are created. So what does the guidelines speak? These are evidences that we're talking about. What does the guidelines speak now? Now the guideline says that your previous goal was 140/90. Now your goal should be 130/80. But not in all patients, selective patients. International guidelines says we stick to the 140/90 because we have resource crunches, we have other issues at hand to deal with. So we stick by 140/90, and even the most of the nations, local guidelines, the Europeans and Americans, they follow 130/80, but other rest of the developing countries, we still follow 140/90, and we are convenient with 140/90. Now, what it says, whenever you want to achieve a 20 mm reduction, 20 mm systolic and 10 mm diastolic reduction. Whenever you want to achieve a 20 mm systolic and 10 mm diastolic reduction, you need to initiate antihypertensive therapy with 2 first-line agents of different classes. 2 first-line agents of different classes. either as separate agent or as fixed dose combination, either as separate or fixed dose combination. So the guidelines are now advocating for using of fixed dose combinations. If not, you use two separate agents, give two drug therapy to your patient, initiate two drug therapy if you want to use get a 20 systolic and 10 diastolic reduction. European guidelines, the updated guidelines, 2018 was the same, and there is little change with beta blockers in the 2023. There is no major update. Only thing is that beta blockers has been added on to the guidelines as a first mainline therapy in these patients, in case the patient has a cardiac disease. So here again, what it says, start with a dual combination. You start with a dual combination, either ACE or ARB, CCB, or a diuretic in these patients. So again, both American and European guidelines, the international guidelines, all guidelines are in favor of using a combination therapy, especially when you want a 20 reduction. So suppose my patient comes with a systolic blood pressure of 170 and my target is on 140. So there is a 30 reduction that I require in my patient. So I would definitely initiate with a single pill dual combination, see how the patient is responding. If the patient is achieving the target, well and good. If the patient does not achieve the target, I escalate the therapy and make it into a triple drug combination. So again, that is also triple drug combination. A single pill triple drug combination is which is favored in these patients. So this is where it says WHO 2021 again mentioned the same thing. Start with two drug combination, preferred a single pill combination. Okay, so all guidelines, irrespective of which guidelines you are following, whether you like American guidelines, European, WHO, international, South African, all guidelines speak in the same language. Use two drug therapy, combination therapy, and a single pill combination is more preferred in these patients. So these are the guidelines they're speaking about. Now let's see why single pill combination is preferred over monotherapy. Why we do not go to our school, college, school, medical schools where we used to give amlodipine 5 mg and escalate it to 10 mg and then start a second drug when the patient was not responding with 10 mg. So here you see an ACE inhibitor, systolic blood pressure reduction is around 12 reduction. ARB is again 12 with 13 reduction. CCB is around 10 reduction is what we see in a systolic blood pressure with a standard dose. Now, what happens when you give a double dose? What happens when you give a double dose? When you give a double dose, there's a 5-fold increase in when you give a double dose, there's only 20% increase in your BP reduction. So if I have reduced by 10 another 20% reduction in the 10 so 10 20% of 10 would be another 2 So my reduction increases by 12. My reduction is 12 Whereas when I add a second drug, I have a 50%, 5% effectiveness is there in my patients, and I have a nearly 10 plus 10, 20 reduction that is seen in these patients. Let's see whether it stands true. So this is your standard drug. So let's talk about the most common drug in CCBs that we have, the amlodipine. Amlodipine is around 8 9 reduction by standard dose, which is amlodipine 5 mg. In case you increase it from 9 to 10 mg to 5 mg to 10 mg, your BP reduction is jumping from 9 to 11 So there's incremental of hardly how much? Incremental of around 3 increase in the blood pressure reduction is what we are seeing. ACE inhibitors, we see again an incremental of hardly 1.5 or 2 increase incremental by doubling the dose we are seeing. ARBs, again, from 10.3, we are seeing a 12.3, again 2 reduction, 20% increment in the dose. So are we getting that 20% reduction by increasing the dose? Are we getting that 10 plus 10 effect? No, we are not getting that 10 plus 10 effect. So what the guideline says is you need to add two drugs of two different classes. You need to start with two drugs of two different classes, and those two should not be ACE and ARBs. ACE and ARBs are not to be combined together. Anything, either RAS blockers, ACE, ARB, along with a diuretic or a CCB would be a preferred combination most of the population. So this is what it says. You don't get the 20 effect in these patients. So monotherapy provides you 10 reduction. Wherever we need a 10 reduction, we go by monotherapy. But when we need a 20 reduction, it is always advisable to go with a two drug combination of two different classes. Now, when we speak about purely African ethnicity, people with African origin, what drug should be preferred in them? So NICE guidelines and the WHO and all international guidelines speak that CCBs and thiazides are the preferred drugs. CCBs and thiazide diuretics are the first line therapy in these set of population. Even the European guidelines, ESC guidelines, they also speak the same thing. Two drug combination is preferred, single pill two drug combination, either diuretic, CCB, and if you're combining, monotherapies are diuretic and CCB, and if you're combining, you need to add diuretic with a CCB, diuretic with a RAS blocker, CCB with a RAS blocker. So this is where the combination goes. So either I use a RAS blocker, diuretic combination, RAS blocker, CCB combination, or CCB diuretic combination. Now, which one is a preferred combination among these things? So these are the three best combinations: calcium channel blocker with a RAS blocker, CCB with a diuretic, or a RAS blocker with a diuretic. Now, which is the most preferred among three? Which is the most recommended? Which one is the most preferred? Which one we should use in a combination? When it comes to monotherapy, you go with a CCB or a diuretic. You choose one of them. But when it comes to combination, should we choose CCB plus diuretic? Should we choose CCB plus RAS blocker? Should we choose diuretic plus RAS blocker? Which one would be the most preferred one? So the diuretics, we know that the American College of Cardiology has clearly stated diuretics are very good drug in bringing down the blood pressure. They are first line therapy, first line recommendation. However, it comes with a drawback. What is the drawback? It worsens your metabolic parameter. Today, we know that most of our patients are diabetic, having metabolic syndrome, having dyslipidemia, having cardiac issues. So diuretics worsen the metabolic parameters in a person. It worsens the gout parameters in our patients. It increases the worsens the impotency in our patient. This erectile dysfunction is more with diuretics in our person. Along with beta blocker, we all know that beta blocker also is known notoriously for erectile dysfunction. RAS blockers provide an added synergistic effect. Let's see what added synergistic effect a RAS blocker would provide with a CCB. When you give a RAS blocker with a diuretic versus RAS blocker with a CCB, your BP the blood pressure achieved with this is, as per the economic study, is much better compared to RAS blocker. It is not that they are not good, they are good, but with a RAS blocker and a CCB, you would achieve a much better hypertension with the patients, blood pressure control in these patients. Second thing, it will not give you the side effects of a diuretic. So side effects of a diuretic, and this is a chart, wonderful chart, which was described in 2010, and this stands very well validated even today. It says very clear chart, very clear message, very wonderfully elaborated algorithm of treatment. It says preferred combination should be a CCB with a RAS blocker. Preferred combination should be CCB with a RAS blocker, or you can use a thiazide like diuretic with a RAS blocker. Alternative is thiazide with beta blocker, and alternative thiazide with CCB. So thiazide CCB, which are the first line therapy, when you give a combination, they become a second line therapy. The first line combination is CCB RAS blocker. If you cannot give CCB RAS blocker, if it is not available, if the patient cannot afford a CCB because of the costing effect, then diuretic with RAS blocker is a preferred first line therapy in case the patient cannot afford CCB or cannot take CCB with a RAS blocker. So RAS blocker with a CCB or diuretic is a preferred therapy, not the CCB and a diuretic, which is generally thought, because they both are your first line therapies. So this is where the algorithm presents that what is the best combination for a patient with an African ethnicity for management of hypertension in combination. When you give a diuretic or a vasodilator such as CCB, the BP falls. When the BP drops, you have activation of the RAS system. Your RAS system gets activated, and this system needs to be balanced. And this balancing will happen when you give a RAS blocker. And that is the reason why you need a diuretic with a RAS blocker or a vasodilator CCB with a RAS blocker as your preferred first line therapy. Otherwise, when you're giving a diuretic with a CCB, you will have excessive activation of RAS activation. And that is why it says you should go with a CCB with a with RAS activation. I heard somebody was making a statement.
No, I think it was just the mic which was unmuted. You can proceed, Doc.
Okay, thank you. So this is where why we should be using a RAS blocker with a diuretic. Now, coming to RAS blocker with a diuretic, that says when you give a RAS versus non-RAS regime, what are the endpoints, cardiovascular endpoints? What effect does it give? It gives you the decrease in cardiovascular death is by 22%. When you give non-RAS regime, there is no difference. When you give RAS regime, in life study, it was around 13% value. There was no difference when you give non-RAS study. And when you give in ASCOT, when you give RAS regime was tested, it said that the cardiovascular death rate was reduced by 24%. So what is our goal? What is our objective? To reduce the cardiovascular complications in my patient. My objective is to reduce the cardiovascular complications in my patient. And if I am not able to be, I'm not just here to reduce the numbers in my patient. I'm here to reduce the cardiovascular complications. And that is where when you have a RAS blocker, when you give a combination, a RAS blocker would be preferred ones. Now, which one to prefer? So, the treatment should be evidence-based. It should be based upon the patient's preference, based upon the choice. So now, this is the counterbalancing about CCP and RAS blocker. When the CCP is what they do is they initiate the RAS system, and RAS blockers they suppress the RAS system. So there is a balance harmony which is maintained in the CCB and a RAS blocker, or a diuretic and a RAS blocker in these patients. Now, among RAS blockers, which one to prefer? Whether you should go with an ACE inhibitor or an ARB? Which one would you prefer? ACE inhibitor or an ARB? What is your take on it? Anyone? So in our medical schools, when we were taught in medical schools, ACE inhibitors were a wonderful drug. It was a wonderful drug for cardiovascular risk reduction, risk prevention. Beta blockers, I'm saying. RAS blockers, ARBs, when it came into picture, it was found that they are as good as ACE inhibitors. We will see that in subsequent slides. But the overall tolerability with RAS blockers, with ARBs were much better than ACE inhibitors. You can see in the standard, in the figure, that RAS blockers, the number of adverse events, the percentage of adverse events was much lower with the RAS blocker, which is in white, was 0 with standard treatment, whereas in ACE inhibitors, there were a considerable amount of adverse events. CCP definitely with edema being one of the major problem. And when you have double the dose again, there is some increase in the ARB adverse event, but in again ACE inhibitor, you have subsequently higher amount of adverse events. So your tolerability is much better with RAS blockers. The patient adherence increases. When you tolerate the medicine better, your adherence is much better with the patient. And that is where it said that on-target study clearly demonstrated that the telmisartan was non-inferior to ramipril, which is an ARB versus ACE inhibitor, in terms of primary composite endpoint, as well as your secondary endpoint of cardiovascular deaths, MI, strokes, and hospitalization. So ACE inhibitors are wonderful drugs. ARBs are as good as ACE inhibitors in terms of their primary objective of blood pressure reduction, as well as their secondary objective of cardiovascular risk protection, and it has better tolerability. And based on these on-target studies and transient studies, it was seen that ARBs are better tolerated, better adherence, and that is why it was preferred. ARBs are better treatment adherence than ACE inhibitor, and better tolerated, and significantly rose the risk of cough and angioedema. I tell this in multiple forums. I was a very young practitioner, just out of medical college, and started practicing in one of the hospitals in Delhi. And we had this patient coming from Afghanistan. So Afghanistan is nearby, so patients fly in whenever they have some medical issues. So the patient was here, was given an ACE inhibitor, and was sent back to home, and she was having dry cough, was treated with various medications there, and nobody took the history. So the patient took a flight after 3-4 months and comes back to India, and then she says that I'm suffering with this cough badly, and that is when we took a detailed history what medicine she's taking, and we found that patient was on Ramipril, and because of that she was having. And as soon as we discontinued Ramipril, her cough disappeared. So you must have seen similar things much in your practice, and that was a turning point where I shifted myself from ACE inhibitor to ARBs, and I started moving from ACE inhibitor into ARBs more in my patient. Definitely, you don't change the winning combination. If my patient is well tolerated with ACE inhibitor and well maintained, I would never touch it, never disturb it. But in new patients, then again, the tolerability becomes a issue where I would definitely like to start with a much safer and much tolerable drug. And we practice shifted towards. So that was a turning point in my practice towards ACE inhibitors, towards ARBs. Now, ARBs, are they all the same? So over the period, you have different ARBs which had come up. Are they all the same? They are all ARBs. Are they all the same? Do they behave in a similar manner? Do they have all the same benefits? No, they are not all the same. So they sound same, but they're not all the same. When you talk about telmisartan has a 24 hours coverage compared to the other drugs. So when you talk about losartan has a smaller half-life. Idea, though the prescribing information says losartan needs to be given once daily, we definitely give it twice daily. Telmisartan has a 24 hours half-life, so you can give it and you don't have to really skip. If my patient takes it at 9, I don't have to tell him that you try and adhere to 9 a.m. He or she can take it at 10, 11, 8. So that flexibility is there in the patient. So that gives an added advantage. It has better, it does not get excreted through the kidneys, it is excreted through the feces. So again, CKD patient, I'm not bothered that, this might accumulate in the body. So these kind of safety issues are there. And the fluctuation in the BP, intraday fluctuation in the BP is very less, is more of a physiological fluctuation with telmisartan compared to other drugs. So the other drugs, if you take some other drugs such as valsartan or losartan, as the drug efficacy is weaning out, and when you take the next one, there might be slight peaks and fluctuations in the blood pressure, which is not good for the patient, and that is why telmisartan today has become a preferred sartan among most of the patients. But is it only the BP effect that is there in telmisartan? So we have some of the other beyond blood pressure effect of telmisartan. We know that obesity is a leading factor for cardiovascular risk. With the HOPE study, it clearly demonstrated that with obesity, the death rate increases. With obesity, the myocardial infarction risk increases. With obesity, overall death risk increases in the patient. The bigger the circumference abdominal girth, the more is the chances of death, myocardial infarctions and other challenges. With obesity, the increases your risk of diabetes. And with obesity, there is an increase in the coronary heart, the coronary artery disease, the coronary heart disease. All these diseases increase with, as you become obese, you are more prone to cardiac problems. Why is it happening? Why? Because obesity causes dyslipidemia, it increases insulin resistance, and it causes inflammation in the body. So insulin resistance will increase your blood glucose levels. Inflammation will make your blood vessels more brittle, more inflamed, more prone to atherosclerosis because of it. And these are the factors. So if you see, this is something which is very common. Chronic inflammation, increase in insulin resistance, metabolic disorders, all these things are caused because of obesity, and all these things, they again lead to obesity. So there's a cycle. You scratch my back and I scratch your back. So obesity increases inflammation and hormonal disbalance, insulin resistance, and these all attribute to further obesity in the patient. And that is a common phenomena today that we see children, kids obese across all societies that we are seeing. When you compare with telmisartan, so when you need to control this hormonal disbalance, chronic inflammation, insulin resistance, so now telmisartan gives you an added protection. It gives you 24-hour blood coverage. That is my primary objective. Second, it reduces insulin resistance. It reduces your HbA1c in your patient. It is not a diabetic drug. It is not a diabetic drug, but it has some sort of effect, gives you an added advantage by acting on PPR gamma receptors, decreases your arterial stiffness. So when your arteries are not stiff, your blood pressure your arteries will expand and relax, contract and constrict much better. And that will give you an added advantage. Help in reducing your inflammatory stress telmisartan helps in reducing inflammatory, it has an antioxidant effect. So all these parameters will help in better smoothness index in my patient. It has positive effect on fat metabolism. It has positive effect on lipid profile. All these parameters, it has positive effect on renal profile, reduces proteinuria in the patient. And that is why it is known as a metabolic sartan. So this is a sartan which is known as a metabolic sartan because it has parameters on metabolic parameters because of its activity on PPR gamma. So this is where we see, because of its activity on PPR gamma, what it is doing is that it is increasing the GLUT4 receptors. And by increasing GLUT4 receptors, what it is doing, it is increasing the insulin sensitivity and reducing the insulin resistance in our patient. And these are all reduce insulin resistance, dyslipidemia, reduction in dyslipidemia, reduction in inflammation, cell proliferation, oxidative stress, hypertension. All these are beneficial in inhibiting the atherosclerotic plaque formation in our body and hence protects our cardiovascular organs or gives us a cardiovascular protection. And that is why US FDA had recognized telmisartan as first antihypertensive drug as a for cardiovascular protection, risk reduction. So first antihypertensive drug was telmisartan, known for your cardiovascular risk reduction or protection. So this is, it shows that it has the highest PPR gamma activity compared to all sartans, because of which it has a positive effect on fasting glucose, positive effect on insulin sensitivity, on positive glycolated hemoglobin, that is HbA1c, and it has positive effects on the hemostasis index and also on the on your lipids. It has a positive effect, and that is why you have reduction. You can see some minor reduction in the abdominal girth once the patient is on telmisartan over a certain period of time. If you give it for 6 months and a year, you can see that the patient has slight reduction in the abdominal girth because of these metabolic parameters. Now, this is a comparison of telmisartan with losartan. You can see HbA1c reduction was considerably high with telmisartan compared to losartan, which had a slight increase. Fasting glucose again reduced with telmisartan. Your postprandial glucose fasting insulin was also reduced with telmisartan compared to losartan. And because of these parameters, it is known as telmisartan is known as a metabolic sartan. Talking about the benefits of amlodipine, we know that amlodipine is the longest acting amlodipine in among all dipines. It has the highest half-life of nearly 30 hours. It has cardiovascular protection. These are various studies, the PREVENT study, ASCOT study, CAMELOT study, ALHART study. All these studies have demonstrated that it not only reduces blood pressure, but also provides you cardiovascular risk reduction. And because of this, it is recommended in coronary artery disease, such as chronic stable angina, vasopressin angina, and even because of heart failure patient with ejection fraction less than 40 or a coronary artery disease patient without heart failure. So these amlodipine is recommended for BP control in these patients. Now, what are benefits of amlodipine and telmisartan? When you add two drugs, when you give a monotherapy, when you give, again, you see that there is a minus 11 reduction with amlodipine 10 mg. But when you give amlodipine 5 and telmisartan 40, you have minus 13 reduction. When you give telmisartan 80 with amlodipine 5, you have around 15 mm reduction in your blood pressure, systolic blood pressure. For proportionate of patients which have achieved your BP goal, again, is highest with telmisartan for 80 with and amlodipine 5, and telmisartan 40, amlodipine 5, you have around 60 mm, 60% patient have achieved their systolic blood pressure of 40 mm Hg, and diastolic is again 86% patient have achieved. So definitely the combination is better than the monotherapy. Rather than escalating from 5 mg to 10 mg, it would be always advisable to shift from 5 to 5 mg to a combination therapy. Or if you're starting in a newly patient, then definitely the guidelines recommends to go with a combination therapy in these patients. So this is the BP reduction with telmisartan 80 and amlodipine 10 with mild, moderate, and severe hypertension. You can see with mild hypertension 20 mm reduction, which is between 140 to 150 systolic, 150 to 167, around 30 mm reduction. And in severe hypertension patient with 180, 190, you see 47 mm reduction is achieved with this. So higher the BP, the severe the blood pressure, the higher the blood pressure, the more reduction we see with the combination therapy. And definitely, if you want further reduction, then you can add a triple drug combination in these patients. So mind it, these studies were done when the guidelines did not come up with the fixed dose combination of recommendation for fixed dose combination of 45 of amlodipine or did not come. These are the studies which were done back in 2010, 2012. At that time, the incremental was you give amlodipine 5, then you give 10, then you add a second drug, then you increase the dose of the second drug, and that is how it went. So it says that nearly 37% of the patient achieved their blood pressure with the combination in 2 weeks. 37% achieved in 2 weeks, and by 8 weeks, nearly half of the patient had achieved their blood pressure targets within 8 weeks of therapy with the combination in these patients. Compared to the patients who have achieved their goals, if you give only amlodipine, it is around 40%. If you give the combination, around 84% would patient would achieve their target goals in these patients. Now, talking about their added benefit, other benefits in just not in BP reduction. Here, if you see diabetic, obese, and metabolic patient, all these patients with moderate and severe hypertension, you can see that there is a considerable amount of BP reduction in these patients, and that is why it is a preferred combination in a metabolic patient or a patient with diabetes, a patient with increased risk of diabetes, or patient who is obese. In all these patients, telmisartan with amlodipine would be a preferred combination. Now, when you talk about safety and tolerability, what about the safety and tolerability? CCBs dilate only the arteries. They don't dilate the venules or the veins. When you give an RAS blocker, what it does, it dilates not only the arteries but veins. So arteries are already dilated. They are further dilated to some extent. They cannot be dilated to the double the extent, but they are already dilated. So you dilate the veins, and when you dilate the veins, the flow of the blood is now smooth, and that is what it does is it reduces the edema, it reduces the glomerular pressure, and that is where it helps in reducing proteinuria, reducing edema in these patients. So that is where when we see adverse events, with 5 mg, you have around 8.6% patient have adverse event. With 10 mg, 27 patient have adverse event of edema. When you add amlodipine 5 with 40 mg of telmisartan, you get only 5% of the patient with pedal edema. And when you increase telmisartan to 80, only 36% of your patient will have pedal edema. So this is countering to these side effect of the of amlodipine of CCB when you add a RAS blocker to these patients. So this is where it says, you can see there's a reduction in the overall complications of pedal edema with amlodipine when you add a telmisartan to these patients, and that is where it says there's a balancing effect with CCB and a RAS blocker. CAMWAT study, ALWAT study, all these studies have demonstrated that CCB amlodipine is cardiovascular protective agent. It has a benefit. It reduces the progression of atherosclerosis and hence gives you a cardiovascular protection. So why should you choose both of them? They have the PK/PD similarity. So you have to give once daily amlodipine, once daily telmisartan. Both of them have a half-life of around 25 and 30 hours. So they have PK/PD similarities in these patients. They provide a good BP reduction. They have a smooth BP throughout the day. So the BP fluctuations are not there, between intraday fluctuations are not there, especially your morning surge is not there. And because we know that morning surge is a period between 6 to 8 a.m. is a period, 5 to 8 a.m. is a period where the BP starts shooting up and where most of our drugs effect is waning out. And that is a period when maximum heart attacks and strokes happen. And that is where these drug combination is quite effective in tolerating. And then it gives you the cardiac protection. And we all know that telmisartan is the only antihypertensive drug which is known to US FDA approved for its cardiovascular protection risk reduction. So at last, hypertension is one of the leading cause of death. It is a preventable cause. It is one of the leading cause. 1 in 3 population is suffering with hypertension. 70% of your patient would require 2 drug therapy or more than 2 drugs for management of the hypertension. And single pill combination is the preferred over monotherapy because adherence increases when you have single pill in these patients. Beta blockers are recommended in heart failure patients. Beta blockers are recommended in patients with coronary artery disease, not the old generation beta blockers, the newer generation beta blockers, because they have less side effects compared to the old generation beta blockers. It has come back in our 2023 hypertension guidelines. And most patients would require RAS with a CCB or a thiazide-like diuretic. So preferred diuretic is RAS plus a CCB or a RAS with a thiazide-like diuretic. And poor adherence is when you give multiple drugs compared to when you give a single therapy. And ARBs are more preferred over ACE inhibitors because of their tolerability and the less side effects. And telmisartan, as we know, is a sartan which is beneficial. Other than BP reduction, it will give you benefit effect in terms of your cardiovascular, in terms of your metabolic parameters, lipid profiles, your sugar, your insulin, and overall abdominal girth, and those things are much better with telmisartan. So that is why it is a preferred sartan in diabetic patient, obese patient, and patient with metabolic syndrome. So I believe I have consumed a lot of time, and with this I hand over the session to the organizers.
Okay. Thank you very much, Dr. Manish, for that informative presentation. I think it was well elaborate and quite informative as well. So I think I know there are some questions that our members would like to bring forward. For now, allow me to move to the next part of the program where we call in one of the representatives from Augusta Pharmaceuticals to present their products, and then after that we can have questions on both their products as well as the presentation that Dr. Manish has given us. So thank you very much, Dr. Manish. I think for now you can rest, then we'll come back to you for the questions.
My name is Pefias. I'm the representative for Augusta Pharmaceuticals. And as Dr. Manish has done the scientific presentation, I just want to highlight on the brand presentations just to showcase some of the products that we have as Augusta and Augusta Pharmaceuticals for this. So for adequate and sustained control of blood pressure, which is essential to avoid increased risk of cardiovascular morbidity and mortality, recent evidence from outcome studies suggests that most patients will require combination therapy to achieve their goal in blood pressure. So the combination of angiotensin 2 receptor blocker, which is ARB, together with calcium channel blocker, CCB, these have a complementary and synergistic mode of action. So therefore, the combination treatment results in a superior blood pressure reduction than either monotherapy in stage 1 and stage 2 hypertension across a range of different patient types, including those with added risk factors such as diabetes, obesity, or metabolic syndrome. So we're bringing the power of 2, that you get more benefits in as a combination as instead of either monotherapies. So from Augusta Pharmaceuticals and from Augusta Pharmaceuticals as Innovata, we are presenting to you as a first-line treatment or for patients whose blood pressure is not adequately controlled with amlodipine alone. We are presenting to you Amlotel. So Amlotel is a combination of telmisartan with amlodipine, and it comes in 4 different strengths of combination, which is telmisartan 40 milligram with amlodipine 5 milligram, telmisartan 40 milligram with amlodipine 10 milligram, telmisartan 80 milligram with amlodipine 5 milligram, and telmisartan 80 milligram with amlodipine 10 milligram. So these are the 4 different, actually these are all the 4 possible combinations of the telmisartan with amlodipine. So the Amlotel offers the fixed dose combination of Amlotel provides a complementary and synergistic mode of action, which results in significantly greater double-digit blood pressure reduction than amlodipine monotherapy. And with Amlotel, majority of the blood pressure reduction is actually observed within the first 2 weeks of treatment. So Amlotel fixed dose combination provides improved tolerability, which ensures patient compliance, and it's also effective across hypertensive populations, including those with high risk, with high cardiovascular risk. Then also from Innovata, we are presenting in stage 2 hypertensives with high risk of stroke and myocardial infarction, as well as in hypertensive patients with stroke whose blood pressure is uncontrolled on monotherapy. We are presenting to you Valvask, which is a combination of valsartan 160 milligram with amlodipine 5 milligram and valsartan 160 milligram with amlodipine 10 milligram. So Valvask protects against cardiovascular and renal morbidity and mortality. Valvask is also indicated in hypertensives who are uncontrolled on monotherapy or patients who are stabilized on valsartan and amlodipine as separate drugs. Then in stage 2 hypertensive with high risk of stroke and myocardial infarction, as well as in hypertensive patients with stroke and uncontrolled on monotherapy, Valvask offers benefits of 2 highly effective and well-tolerated antihypertensives. So the valsartan with amlodipine as individual drugs given monotherapy, these reduces the cardiac morbidity and mortality. They also lowers the fatal stroke and non-fatal stroke and myocardial infarction. Valvask also reduces the risk of hospitalization for heart failure. And the two, as a combination, they offer a powerful blood pressure lowering with a dual mode of action, and they are also favorable. They also have favorable safety profile. So from Augusta Pharmaceuticals, that was the brand presentations. Thank you.
Thank you very much for that presentation. I think at this point, without wasting much of our time, I would like us to go straight into the questions. I know there are some concerns and there are clarifications that our doctors may have. So I would like to call back Dr. Manish to be ready as we bring forth the questions. So Dr. Kalenga, you can go ahead.
Yeah, so I can see a couple of questions on the chat box as well. Maybe we can take that also.
Thank you so much,
Yeah.
Dr. Manish, for a very informative presentation. We've learned one or two things. Dr. Kalenga, working at TMS Hospital. We've learned a lot. It was important to really attend this presentation. But there are one or two things that you wanted to bring as contribution. Maybe you can. We are going to come in as maybe a reply. It's not a direct question, maybe indirect with some small contribution.
Mm-hmm.
We're not going to scare our pharmaceutical companies. We are going to give some small ideas, contribution. We've seen the best condition for a human being. The best thing is one being healthy, meaning you don't have any headache, any problem with the high blood pressure, any metabolic condition, meaning one is free from any medication. That's the best situation. But when it comes to the point that one is not healthy, maybe having headache, or one is having high blood pressure, one is suffering from sugar disease, diabetes, or any other condition, metabolic syndrome, we are going to go with some management plan. In the management plan, the pharmaceuticals tend to let us know that we only have to go with the medicine, prescribing medication. We see even a couple of some of our specialists, consultants, or some other doctors, even GP, when the patient is found to have high blood pressure, or is suffering from sugar disease, diabetes, or any other condition, we tend to forget the other interventions for the management for those conditions, like high blood pressure, or diabetes, or metabolic syndrome. There is no single intervention that is the most important, which works in all the cases. We go with combined interventions. We have pharmaceutical management and pharmacological management of high blood pressure, and non-pharmacological management of high blood pressure, sugar disease, and any other condition. So we wanted just to remind our doctors on this forum that we need to go with the combined intervention. We've seen, even as we are coming for the blood BP management with the advice from this presentation to give combined medication, we need to consider patients on a case by case, also classifying the people with high blood pressure. We have mild hypertension, moderate hypertension, and severe hypertension. So in those different cases, management, or even we just focus on the pharmacological management, since this is a topic for today, we are not going to all the patients with mild hypertension, moderate and severe hypertension on all those combined, on the combined medication. No, one with the mild hypertension, the guidelines, they advise us to start with the, if somebody who comes with a BP, high blood pressure, a young person.
Dr. Kalenga, hello.
Yes.
I think for the sake of time, I think the point has been gotten. Sorry to cut you short. I think you are trying to encourage the approach where we go non-pharmacological and as well as pharmacological management. I think the point has been gotten. And I'm sure at this point, Dr. Manish, we are in a situation where the patient has come with BP 200 over 120. It's difficult to tell this patient to go and run. But at this point, maybe we are going straight into pharmacological management. So I think that point has been gotten. So I'll guide Dr. Manish, maybe we can address the questions that you got from the chat box, as well as highlight on what Dr. Kalenga has brought forward.
So I totally agree with Dr. Kalenga that BP is not only about pharmacological management. It is a lifestyle disease. The first thing, diabetes, hypertension, dyslipidemia, thyroid, hyperthyroidism, all these are your lifestyle disease. So what we need to do is correct our lifestyles first. And pharmacological medicine, they help as an add-on, helping tool in getting our BP control or BP goals. In case my patient is at high risk, I would not wait. I would definitely put him on therapy. In case I need a 20, as he said, not everybody needs a combination therapy. You need 10 mm reduction, go for a monotherapy. You need 20 mm reduction, go for a combination therapy. So you need to set the goal in your patient. You need to sit with your patient, understand your patient. We have to see what my patient's risk factors are, what are his end organ status. If he has got a cardiac disease, I will not wait for him to come back after for risk management. I would start with the therapy, but definitely you need to advise your patient for a lifestyle modification, physical. So there is a rule of 5, which says if you reduce your diet, salt intake, you have a proper diet, you have a proper aerobic exercise, physical activity, all these parameters will help you reducing your blood pressure by a 5 mm Hg of reduction in your blood pressure. 1 kg reduction will lead to 1 mm reduction in the blood pressure in your patient. So you need to motivate your patient to adopt these lifestyle changes. As we do it for even diabetes, we motivate our patient to go for lifestyle modification. But in case they cannot, then we need to definitely go on a therapy. There is no other second resort that we have in our therapy. So I agree with him, but then definitely most of our patients would require pharmacological intervention.
Yeah, so I don't know if you took note of the questions in the chat box.
Yeah, I have the questions in the chat box. So CCB has been largely preferred in pregnancy. So when it is said CCB, it is nifedipine which is preferred in pregnancy, not amlodipine, benadipine, ephedrine, or any other dipine. It is the nifedipine which is preferred in pregnancy and which has some effect even in proteinuria reduction in these patients. Telmisartan, obviously ARBs and ACE inhibitors are not preferred in pregnancy. In case your patient wants to become pregnant, is planning to conceive, stop telmisartan in your patient, stop ARBs, stop ACE inhibitors in your patient. If the patient is on any RAS blocker, diuretic, or beta blocker, except labetalol, then you need to formulate your therapy in your patient. So the drugs which are used in hypertension or management of hypertension are methidopa, your nifedipine, and labetalol. Methidopa is my personally most preferred one. Why? Because it is cheap. It is very cheap. Second thing, the there's enormous data that, patients have been followed up for 11 years in Finland, where they have seen that there is no problem, no added disadvantage with methyl-dopa when you give this drug to your patient. Only thing is that some dosing inconvenience with these patients. Otherwise, nifedipine and labetalol are the other two drugs other than methyl-dopa which are preferred over here. So, which is the best combination in pregnancy? Again, I would go for methyl-dopa. Does not help. I would go with a nifedipine or labetalol, whichever is available, and then further go with the. If I need to have a triple drug, then methyl-dopa, labetalol, and nifedipine and nifedipine would be the triple drug combination if I have to go. In view of low therapy range of amlodipine, side effects are common. So if you want to replace ACE inhibitor or ARB, either you should go with a diuretic in such cases. If you want to replace it with, if you want to replace monotherapy amlodipine in an patient who is of African origin, then definitely the drug monotherapy would be a diuretic. If you are giving a combination therapy and ACE with RAS blocker, amlodipine CCB plus RAS blocker is not effective, then you need to go with diuretic with RAS blocker or maybe a diuretic with CCB, which would be a preferred combination in these patients, if it is in these patients. Talking about U curve and J curve phenomena, J curve phenomena is a phenomena. You reduce the risk of hypertension when you bring the blood pressure down, but when you bring it further down below 120, when you go further down, you increase the risk of cardiac disease. That is what is the J phenomena speaks about, and it is a phenomena which is irrespective of which country you are, which origin you are, which ethnicity you are. This is common for everyone. It has been observed in the studies in US that all ethnicity people of all ethnicity face this J curve phenomena. So if you further lower down your blood pressure below 120, which is not recommended by the guidelines, that you should lower it down below 120 so that the patient does not have these problems of cardiac disease.
Or concerns or additions?
So one question is ACE inhibitors are far more affordable than ARBs. In the place where we are sitting, ARBs and ACE inhibitors, they cost the same. But yes, affordability does matter for the patient because we are in a resource limited setting. And when the affordability is well tolerating the ACE inhibitors, then I think you can still continue with the ACE inhibitors. You don't have to really change it for your patient. And the similar with CCB and diuretics as well. So the guidance very clearly says you use a CCB. In case the patient does not use a CCB, is not affording or is not available, then you go for with a diuretic. Similarly with ACE and ARBs also. In case my patient is not able to get ARBs, there's affordability cost, patient has an affordability issue, I would definitely then in that case go for a ACE inhibitor. So losartan is readily available compared to telmisartan. So these are local issues. Telmisartan, if it is not available, then definitely you do not have a choice. You have to write whatever is best available in particular area. So that is where it goes on.
Okay.
I think
yeah. Okay, there is a hand. You can go ahead, Pauline.
Okay, thank you. I'm afraid I missed his description of those phenomena. Something was wrong with my network. Could you just go over them again?
The U and J?
Yes,
okay.
yes,
Come again with the question.
The U and J phenomenon.
Okay, J curve phenomena. So as I said, J curve phenomena is a phenomena when you reduce your blood pressure. So it is a phenomena. I'm bringing down the risk factor, the cardiovascular risk factor. So when I'm bringing down the cardiovascular risk factor by lowering the blood pressure, when I further lower the blood pressure, then you have a J curve phenomena or a U phenomena where you're increasing the risk. So as if I'm going down, the patient is now was hypertensive, I brought him to normotensive, and now when I'm reducing the blood pressure further, the patient is becoming hypotensive. And when you become hypotensive, your risk of cardiovascular disease increases. Now, for example, I'll tell you my personal experience. My father, we have a hereditary problem of low blood pressure. My blood pressure remains around 110, 115. My sister's blood pressure remains around 95 systolic. So this is our family problem. And when my father was admitted during COVID in the ICU, so the day one itself, they wanted to put an inotrop because they felt that the blood pressure has dropped because of the COVID infection. But then I had to explain them that no, this is our blood pressure. 100, 105, 100, 95 is something systolic which we have on a daily basis. So then that was the phenomenon, that this low blood pressure is an added risk to your cardiovascular event. So if you go down with the blood pressure, when you're bringing the blood pressure down from 160, 170, you're reducing the cardiovascular risk. But if you're going further down with the blood pressure, you are again increasing the cardiovascular risk. So that is what is called as J-curve phenomena or the U phenomena. And that is where the guidance is very clear about it, that your target should be 130 by 80. If you can bring it to 120 by 80, good, but don't get it below that.
All right. Thank you very much, Dr. Manish and Augusta Pharmaceuticals for this program. I think at this point, I would like to call in the Medical and Research Board Chairperson, Dr. Chuma Njovu, just to come and give us the closing remarks. Dr. Njovu.
Great. Good afternoon, colleagues. Are you able to get me from this side?
Yes, Chair, we can get you.
Thank you so much. I would like to thank, first of all, all the Zambia medical members that have logged in, taken time to log into this continuous medical education. At the same time, I want to thank Augusta Pharmaceuticals for sponsoring and having arranged this scientific topic, enlightening us on the current trends in the management of hypertension. Dr. Nguira, you've been excellent. You're always excellent. Thank you so much for anchoring the session throughout. Mine is just a call to the Zambia Medical Association members that these are a series of CMEs that we'll continue having. And again, this is in response to what the Health Professions Council of Zambia has emphasized on time and again, that the professional development points, the CPDs, will now be mandatory for practitioners that intend to renew their practicing license starting the year 2025. And coming from that, I think it is our mandate as an association that creates quite many forums and platforms for our members to continuously develop in various fields. So we'll have series that will be held virtually and other series that will be held practically. And I think I'll take this opportunity to announce that on Wednesday next week, we'll have yet another physical meeting that will be held at Ridgeway Southern Sun Hotel. 2 weeks after that, we're going to Eastern Province, and then we'll be moving around provinces so that we make sure that all the members are not left out. So thank you all for attending this scientific session. Wish you a pleasant evening. And Dr. Manish, thank you so much. I know it's quite late in India there, but thank you for staying up late and enlightening us through this program. Thank you so much and have a blessed evening.